the NSA and the executives. Okay, so we are deeply grateful to the Educational Committee led by the President-elect of PNETCAM for the support, for making this possible, this resilience webinar series possible. And we are also very, very grateful and indebted to the NSA executives led by the President, Professor Al-Hassan Dati. Without further ado, my name is Dr. John Afam. I'm the trainee representative of the Nigerian Society of Anesthetists, and it is my pleasure to introduce our moderator for today on this 11th session of the Residence Webinar Series of the Nigerian Society of Anesthetists. Our moderator for today is Dr. John Etsuk Anyeti. He's a registrar with the Department of Anesthesia, University of Uyo Teaching Hospital, Akwa Ibom. So welcome, Dr. John, and you have the floor. Welcome, sir.
Thank you very much, Dr. Jonathan. A pleasure to be here amongst all of us. A very special good evening to everyone here present. Good evening to our consultants, our professors here present, consultants, our chiefs and our trainers. You are very, very much welcome to this 11th session of our webinar series. Today we'll be taking on the topic postoperative cognitive dysfunction and delirium. Our presenter is Dr. Salawudeen Bolanle. She is a senior registrar in the Department of Anesthesia from General Hospital, Lagos State. Very shortly, we'll move into the presentation, but we have to establish some ground rules before we move into the presentation. In order to maintain decorum, we please crave your indulgences that we should all have our mics, our microphone muted, and our videos also blocked for smooth running of this webinar series. If you have any questions before the end of the presentation, you can put them in the chat box. Your questions will be appropriately communicated to the presenter at the end of the presentation. Please, as much as possible, let's try to reduce interjections during this presentation. So very shortly, Dr. Salawudeen will take us on the topic post-operative cognitive dysfunction and delirium. Over to you, Dr. Salawudeen.
Good evening. Standing on the existing protocol, as I've been introduced as Dr. Salawudeen Bolanle, Senior Registrar, Department of Anesthesia, General Hospital, Lagos Unit. So we'll be discussing post-operative cognitive dysfunction following this outline. So as our topic is about cognitive dysfunction, so we need to check what is cognition. So cognition is invisible activities carried out by the brain. This involves the insights, the perception, reasoning, analyzing, judging, generating ideas, remembering things, and ability to think. So in this case scenario, we have Mrs. AI says that about 6 months ago, a 70-year-old father underwent hip replacement surgery. After the surgery, he is not the same again. Like that's how it's usually reported by a layman. He forgets things, and we asked the same thing several times. She says father was sharp as tack before operation. He is now less than 80% of himself. So what went wrong in this patient then? So we see that the case scenario is Mrs. AI. Usually it's someone reporting because the patient might not be able to identify that something is wrong with him. So it's usually the relative or the carer that will report it. And we note the time 6 months ago. A 70-year-old man underwent hip replacement surgery, a painful procedure. Then after the surgery, it's not the same again. He forgets and he repeats, he asks the same question over and over, and it's not the same. The father used to be as sharp and tact before operation, meaning that there was no prior cognitive impairment or any form of delirium. And he is now 80% of himself. That is, he's not 50, 10, or 0. There's no loss of consciousness and he's not in coma. But what went wrong with these patients? So that takes us to introducing today's topic. Post-operative cognitive dysfunction was first described by Bedford in 1955 in Lancet Journal as simply advanced cerebral effects of anesthesia on old patients. It transcends disturbance that can affect people of any age, but more common in older people. So, and prognosis can last longer than delirium or leading to permanent impairments. Early intervention is crucial to minimize the sequelae that comes with delirium. So, defining post-operative cognitive dysfunction as a neurodegenerative condition or deterioration in cognition acquired after surgery and anesthesia as quantified by neurophysiological tests. The image on the right shows normal cerebral cortex. It shows the normal hippocampus, the ventricles are normal, and the limbic system. But the one below shows form of neurodegeneration. You see the ischemic cerebral cortex, you see the enlarged ventricle, and as well as the hippocampus, and we know the function of this area. By the National Institute of Aging and Alzheimer's Disease, they said that it's similar to Alzheimer's disease in symptoms and in risk factors. Post-operative cognitive dysfunction is defined by the diagnosis and statistical manual of
Moderator or something.
Sorry for the break in transmission. I guess the presenter might be having some network issues there. But I'm trying to. Okay, I think she's back.
Okay, the moderator, you mute all and you muted me as well. Can I be heard now?
Welcome back, presenter. Please, you can be
I
heard,
think in
please.
the process of muting
Yes,
the
yes.
interference,
You may have
you got me
muted
muted
everybody.
as well.
Sorry about that. Please, let's all try to mute our microphones once we join the platform for easy flow. Please, we'll go back to the presentation immediately. We stopped at definition. Where we stopped hearing you was from the definition of post-operative cognitive dysfunction according to DSM-5.
Okay.
Please, you can continue. Sorry about that.
All right, thank you. Traditionally, delirium is defined by the Psychiatric Association. So the American Psychiatric Association defines delirium as a disturbance of consciousness, attention, cognition, and perception, which develops over a short period of time, usually hours to days. It tends to fluctuate during the course of the day. It is a spectrum of disease rather than a single entity. That's why I have that image here saying the same type of the day. Sometimes the patient is active, restless, agitated. At another time, the patient is just not speaking, anhedonia, and the mood is low. For the acute criteria for delirium, according to the Diagnostic and Statistical Manual of Mental Disorder, in their 5th edition, that delirium, and also by the American Psychiatric Association, that delirium is a disturbance in attention and awareness. It's of acute onset and fluctuates in severity. It's an additional cognitive disturbance or deficit in patients that has a prior cognitive, one form of cognitive deficit or the other. Is not better explained by another neurocognitive disorder like dementia, Alzheimer's, and not due to severely loss of consciousness or coma, and evidence of direct physiological consequence. Here we talk of evidence of anesthesia exposure, surgical exposure, or a form of trauma. So the WHO infection classification, also a 10th edition, also include emotional disturbances, psychomotor disturbances, that is, it could be agitation or restlessness, and a disturbance in the sleep-wake cycle. So, are you at risk of postoperative cognitive dysfunction? Because I think in the definition I said any age, though more common in older people. So according to the APA as well, age 18 to 39 is having 36% risk. Age 40 to 59 is having 10.4% risk. And age over 60 years old, 41.4% risk. These statistics are for major but non-cardiac surgery. While cardiac seems to have the highest 30 to 50% of cardiac surgery, vascular surgery, or orthopedic surgery, because these are longer surgeries, they are more invasive and pain, and patients is exposed to longer anesthesia time. Or patients with pre-existing cognitive dysfunction is at risk of post-operative cognitive dysfunction and delirium. Patients with type 1 and type 2 DM, but the degree of risk in this kind of patient is influenced by the sources of their glycemic control. Also, there is research on patients living in high altitude, because brain cell vulnerability to low oxygen level begins at high altitude. But though high altitude tends to boost cognitivity, though the research is not certain. And I would say this is maybe because the adaptation to that low oxygen, that hypoxia, will help to reduce mobility from cardiac diseases because of the increased vascular function and neutralizing free radicals. So That's how the little explanation I can use to support that. But here, in a study done by J.O. Yaria et al. Of 32 patients on medical ward tertiary hospital in southwest Nigeria, a frequency of 21.3% was observed, which was relatively low compared to other percentages we are getting across board. So there is correlation of post-operative cognitive dysfunction with increasing age and a longer duration to surgery. Well, for delirium, patients from nursing homes with pre-existing cognitive impairments are at high risk. These patients may develop delirium after relatively minor surgery, such as UTI, or patients with low vulnerability may require major insults, such as overwhelming sepsis. What I'm saying here is that patients with high vulnerability, a minor insult can tilt them to delirium. While patients with low vulnerability, we have major exposure to stress, insult, form, diseases, surgery, anesthesia before they can be tilted to delirium. So increasing age and lower economic status level is also implicated here. So, and there's a table of predisposing factor and precipitating factor. The age, cognitive impairment, complex comorbidities, if exposed to the precipitating factors of sleep disruption, emergency surgery, significant intraoperative blood loss, poorly controlled pain can make patients to have post-op delirium, from emergency delirium to post-op delirium, and if the sequelae is not controlled, it leads patients to post-operative cognitive dysfunction at the long term. So the risk factor is multifactorial with varying underlying vulnerability as and precipitating factors. So this is a table just enlisting the risk factor for post-operative cognitive dysfunction and the time frame of delirium to post-operative cognitive dysfunction. Pre-op, patient does not have, assuming the patient does not have any comorbidity, then at emergence or at PACO, the kind of symptoms, signs that we've described, we'll just call it emergence delirium. But if this persists 24 to 72 hours post-operative, okay, we'll be assessing patients for post-operative delirium. But if it continues weeks to months, then patients will have to be assessed for post-operative cognitive dysfunction. So these are signs and symptoms associated with delirium. Change in level of arousal, starting from immediate post-op. Change in level of arousal, drowsiness, or decreased arousal, or increased arousal in case of those with hypervigilance. Then delayed awakening from anesthesia. So these are the kind of patients we have to follow up days, weeks after. Then it goes on to abrupt change in cognitive function, worsening with confusion over hours to days, difficulty tracking conversation or following instructions, quick changing of emotion, easily irritability, tearfulness, uncharacteristic refusal to engage in any activity, expression of paranoid thoughts, delusion, new perception of disturbances, seeming like hallucinations, sleep-wake cycle changes, such as sleeping during the day and awake during the night, decreased appetite, goes on to incontinence, urinary incontinence, or incontinence in stool. Then fluctuating symptoms and levels of arousal within minutes, hours, like that. Meanwhile, signs for post-operative cognitive dysfunction here. Patient is feeling fuzzy, incoherent, memory impairment setting in, loss of concentration, short attention span, up to personality changes, social interaction changes, disorientation, depression, loss of perception, and impaired performance in intellectual tasks. Remember our case study. So what are the causes? Most theories are focused on surgery, anesthesia, and inflammation, basically. that it leads to brain toxicity and brain cell death. There wasn't a whole lot known yet until there wasn't a whole lot known about this syndrome, and the information in some peculiar regions wasn't enough until 2016 at the Alzheimer's Drug Discovery Foundation, centered with brain dysfunction discussion group at the New York Academy Conference on surgery and cognition, delirious cognitive decline, and opportunities to protect the brain. So this led to discussion of the challenges and opportunities to creating biomarkers and therapeutics for patients vulnerable to delirium, vulnerable to cognitive dysfunction, and dementia after surgery. So they formed this BioCog study. What their goal is to get 1,200 patients from 65 to 80 years having some types of elective surgery, need to last for more than an hour, and they study these patients for a long time. Considering the day they get to the study, that is the day of surgery, they have an MRI, they have neuropsychological tests, geriatric assessment, and some other batteries of tests. That's on the day of the surgery. And post-op, day 1 to 7, this screening continues on the day of discharge, another assessment, another 3 months after the surgery, another MRI assessment, neuropsychological tests, geriatric assessment, repeated after a year of surgery to 2 years after surgery. And they got multifactorial answers of the type of surgery that are likely to tilt patients to this cognitive dysfunction, anesthesia, or is there decline from the decline in MRI or neuropsychological test decline, changes in blood tests, whether or not patients get this post-operative cognitive dysfunction and delirium. So the stress of surgery was majorly implicated. Just patients going for surgery, even without anesthesia, any type of anesthesia whatsoever, is at risk of post-operative cognitive dysfunction. And this is caused by any type of surgical trauma through series of sensors, effectors, inducers that could lead to possible cognitive decline because of the exchange that happened between the bloodstreams, and this leading to tissue ischemia, some cell damage, some oxidative attack on the tissues that ultimately can lead to disruption of informations in the brain. So, and this is how post-operative cognitive dysfunction is assumed to set in. Just from surgical cuts, the blood is opened up, cytokines migrating to the brain, inflammations. So, the pathophysiology posters, there is emerging evidence regarding neuroinflammatory etiology of post-operative cognitive dysfunction. We've discussed the surgery, now the inflammatory, then we'll discuss the anesthesia theories. So the theory suggests subclinical inflammatory state priming the CNS, activating neuronal tissue, including microglia and astrocytes. When exposed to noxious stimuli, these prime neuronal tissues release cascade of inflammatory cytokines and mediators, resulting in neuronal injury, including damages to the blood-brain barrier. So this damage to the blood-brain barrier, production of inflammatory mediators, can accumulate in post-operative delirium. So there's another theory pathway, anticholinergic pathway, whereby cholinergic deficiency causing decrease in acetylcholine neurotransmission, thus disrupting cognitive function like attention, memory, and arousal. There is also the large neuronal amino acid theory, like the dopamine, increase in dopamine causing increase in dopamine with prior discussed decrease in acetylcholine will precipitate increased neuronal excitability, thus causing delirium. And the involvement of other neurotransmitters such as GABA, endorphins, glutamate, or histamine is unknown. Then another of the neuronal amino acid is the tryptophan. Decrease in tryptophan, which is a precursor for serotonin and melatonin, means decrease in serotonin and decrease in melatonin. And this will now be making patients to have hyperreactive delirium, where the precursor is increased, there will be increased serotonin, increased melatonin, and the patient will be hypoactive. Another neuronal amino acid is phenylalanine, which is actively transported via the same transport channel as tryptophan. So excess phenylalanine, which shows deficient tryptophan, and deficient tryptophan is decreased serotonin, decreased melatonin, and hyperactive delirium. So phenylalanine is converted to dopa, bringing us back to the other amino acid, dopamine, which is because it's a precursor for dopamine, noradrenaline, and adrenaline. So when it's high in level, its high level has been associated with delirium. So this is just a cascade of the oxidative stress that I've discussed earlier. Now the anesthesia part of the theory. As opposed to the phenomenon that more is better, I think less is probably better in terms of anesthesia amounts for the brain. Minimum monitored anesthesia care and then regional anesthesia is probably safer than general anesthesia care for the brain. Though we cannot universally say that is positive, because in the brain, there is this beautiful symmetrical lipid bilayer that anesthesia disrupts upon introduction of anesthetic agents in form of vapor, in form of intravenous injection. It causes disruption of this lipid bilayer. Then upon awakening or emergence, it is expected that these bilayers symmetry should return to their initial form, but it probably takes a longer time for this to happen. And the longer it takes, the more it goes from emergence delirium to postoperative delirium to postoperative cognitive dysfunction. That's all about the pathophysiology. Classification of postoperative cognitive dysfunction. The acute one develops within a week of surgery and is associated with higher mortality rates. The intermediate POCD develops within 3 months following surgery, which is most common, while the persistent or long-term postoperative cognitive dysfunction develops 1 to 2 years following surgery. 1% of patients is said to have persistent POCD. While classification of delirium can be classified into hyperactive or hypoactive or mixed. Hyperactive patient is agitated, patient have some forms of hallucination, patient is restless and aggressive. Hypoactive patient is withdrawn, drowsy. This is more common and is harder to detect. So it has a higher mortality rate. And we have mixed. So of which the mix is 54.9%. The hyperactive delirium patients are usually agitated, aggressive, combative. We have 1.6%. Hypoactive can have both anhedonia and decreased alertness of 43.5%. Hypoactive subtype can be particularly difficult to diagnose, leading to missed treatment and leading to increased mortality. So a validated screening tools for the diagnosis of delirium on medical ward are the 3 diagnostic confusion assessments method and the 4 ACE tests. We also have the one to screen in ICU, the intensive care delirium screening checklist. This one is done 8 hourly, but it has 64% specificity because it's subjective and patients have to be aware that you're asking him or her question. So if patient is really attentive, then while we're assessing the patient for delirium. So comparing the 2 tests, 3D, that is the 3-minute diagnostic assessment for confusion assessment method, and then the 4 A's, that is checking alertness, checking for the attention, acute changing or fluctuating, And the abbreviation mental test 4, that one you ask for the patient's age. If the patient, you'll be aware of the patient's age, but you just want to correlate if it's correct. The age, the date of birth of the patient. You ask the patient, where are you now, the place you are, and the year that we are. So the purpose for 3D is operational. It's the gold standard. For 4.8 is rapid, is an initial assessment tool. And the administration for the 3D, it has 20 questions to be interviewed, while for the 4A is 4 item bedside assessments, no interview per se. And the 3D, 3 diagnostic confusion assessment method is completed approximately within 3 minutes, while the 4A is less than 2 minutes in most cases. The training required special training for the 3D camp, while for 4A is any designated healthcare professional without acquiring special training can do it. So the scoring and the inclusivity, the validation for 3D CAM shows high sensitivity of 95%, while for 4AD, the A question test is more extensive and is also included in emergency department and general ward. So diagnosis that's for delirium. For post-operative cognitive dysfunction, no real consensus of what tests define post-operative cognitive dysfunction in literature. It involves battery of tests available to measure cognition, the mini mental state examination, the Monter cognitive assessment. I will show the paper in the next slide. This one is very sensitive to post-operative cognitive dysfunction. The cognizance sheets, the post-operative, that's PQRS sheets, then the clock in box. So the one on the left is the Montre. We ask patients to identify numbers and alphabets mixed together, then identify the animal. We want to assess the attention, concentration, then the mini mental test, the orientation. You ask, what year are we, what season are we, what day, what month, then how the language, they have their score allocated, the cognizance and paper. I'm sure this one is regularly available in psychiatry clinic. Then the clocking box, you can draw a circle as the patient to label 10 o'clock, 8 o'clock, 7 o'clock, or you label with numbers, but you don't put the clock hand. You ask the patient to put the clock hand. So anesthetic consideration for patients at risk or not at risk. Anesthesia has been implicated. Since anesthesia has been implicated in the pathogenesis of delirium, it's unclear if choice of anesthesia is significant. Is it GA, general anesthesia, is it regional, is it the conscious sedation? But bispectral index-guided anesthetic care is associated with reduced incidence. BIS monitored used to guide titration of anesthetic drug and depth. The bispectral index derived from analysis of patients' EEG, values between 0 to 100, a target value between 40 to 60 is ideal for general anesthesia. Then for benzodiazepines, midazolam identified as a risk factor for delirium in post-surgical and also in ICU. So routine use of benzodiazepine as pre-medication should be discouraged, except in cases of anxiety and alcohol withdrawal. So we'll also be considering, can I then use imidazole group of induction agent for these patients? But we should note that desmet editonidates and alpha-2 agonist as demonstrated to have reduced incidence of delirium in patients older than 65 years after non-cardiac surgery when given prophylactically at 0.1 microgram per kg per hour, also when using ICU. Then avoiding prolonged fasting and the maintenance of hydration are important intervention that can reduce postoperative delirium. Also, class of phenylcyclidine, which the prototype is ketamine, which the prototype is ketamine, is an NMDA antagonist with psychoactive properties, shows promising benefits for reduction in delirium when given prophylactically in small trial in cardiac surgery. Sub-anesthetic dose of ketamine has demonstrated to reduce post-operative markers of inflammation because it has an analgesic property, and it will reduce opioid consumption, as well as that ketamine has antidepressant effects, but larger rates of hallucination and nightmares has been reported with increasing dose. Also, pain control is another consideration. Using multimodal regimen is an important preventive strategy for delirium. The neuralgia block, though epidural has also been implicated because of the introduction of catheter. In fact, introduction of catheters, urinary tract catheter, epidural catheter, central line catheter, those ones, they put patients at risk of cognitive impairments because of bridge in barriers. So prevention, identification of at-risk patients and targeted prevention may reduce incidence and severity of delirium. Acute medical issues treated promptly, or reorientation strategy should be employed, and family members should be involved if they are available. Mobility should be encouraged where appropriate. Strict bed rest might be avoided. Nutrition and food therapy should be optimized. Medication management should include avoidance or reduction of benzodiazepine and anticholinergics. So management, we have pre-operative, we have intraoperative and post-operative strategy. For pre-operative optimization rehabilitation, we avoid the known perioperative triggers, delirium intervention programs, avoidance of sedative pre-medications, avoidance of prolonged fasting, nutritional optimization, where we get many of the amino acid and other nutrients, magnesium as well for neuronal development or neuroprotection. Then correcting anemia, correcting electrolyte imbalance. Intraoperative strategy involve balanced anesthesia technique, use of short-acting opioid, optimal depth of anesthesia, general versus regional, no difference discussed yet, maintenance of adequate cerebral oxygenation, avoidance of benzodiazepine, avoiding hypoxia, hypotension, hypothermia because of oxidative stress. Multimodal pain management. Post-operative strategy include early mobilization and exercise, support of circadian rhythm, vision and hearing aid if required, avoidance of high-risk drugs, avoidance of polypharmacy. Post-operative pain management cannot be overemphasized. Early removal of urinary Foley's catheter, hydration and maintenance of electrolytes. There are novel therapies, use of COX-2 inhibitor, use of statins, use of pregabalin to alter release of neurotransmitter, desmetamidine, ketamine, lidocaine as also for pain, to stop pain management, minocycline antibiotics, vagal nerve stimulation because they present more of parasympathetic symptoms, and also alloperidol as well. So we have behavioral and non-pharmacological strategies enlisted. I'll be informed for my time. Okay, sensory enhancement, cognitive orientation, pain control, nutrition, food, sleep enhancement, and daily rounding with multidisciplinary team to enforce intervention. So in summary, perioperative delirium is a common and potentially preventable cause of morbidity. While there is extensive international literature on post-operative cognitive dysfunction and delirium, more localized research is needed to understand the local burden of these conditions and to develop targeted intervention for Nigerian population. There is insufficient evidence to recommend specific anesthetic techniques for the prevention of this condition. Since we are still in the line of summary, so there's this imaging of before surgery, In this case, let's say patients have neurocognitive disorder, mild to moderate, and while post-operative still on admission, patient is still having some kind of agitation, restlessness, or patient still remain drowsy. Okay, we'll now be assessing for post-operative delirium, and it continues within 30 days. This one is getting to delayed neurocognitive recovery, and by the time it's extending up to past a month to 3 months to 6 months, within 12 months, then we'll be assessing patient for post-operative cognitive disorder. I want to believe I'll be able to summarize this, and these are my sources. Thank you for listening, Ma. Thank you for listening, sir.
Thank you very much, Dr. Salahuddin, for the presentation on post-operative cognitive dysfunction and delirium. Dr. Salahuddin has successfully taken us through the definition of post-operative cognitive dysfunction and delirium as defined by APA and DSM-5. She has also told us of the risk factors, the symptoms, tried to elucidate the pathophysiology of how this cognitive dysfunction comes about. She's told us also about the anesthetic management and considerations for patients who have risk factors for postoperative cognitive dysfunction and delirium. And she has successfully summarized and concluded. Going forward, we would like to take questions, clarifications, and comments, starting with the residents. Please, if you have any question, you can raise your hand. You will be recognized and you can unmute yourself to ask, or you can put your question in the chat box and it will be read out.
Recording in progress.
Welcome, Dr. Akorede Olabode. He has the person has a question on. The question is what is the most implicated induction agent to cause post-operative cognitive dysfunction? Hello, Dr. Salahuddin, are you with us?
Okay. I'm still
Someone is
unmuted.
asking.
I would say the benzodiazepines. At least not the imidazoles, not ketamine. But we'll not be able to say, okay, it's more of GA or it's more of Meresia blocks.
Thank you, Mas. Earlier elucidated in the presentation, the anesthetic technique of choice has not really been implicated, whether a general anesthesia is better than a local or regional block rather, but it's been elucidated that benzodiazepines have been implicated to cause postoperative cognitive dysfunction. Another question says, what is the connection between indwelling urinary catheter and postoperative cognitive dysfunction? What is the connection between indwelling urinary catheter and postoperative cognitive dysfunction?
Not to single out a urinary tract catheter. It's just catheter burden on the patient, exposing the patient to urinary tract infection, especially if patient is on the high vulnerable patients. So as minor as urinary tract infection can tilt the patient to sepsis and cognitive impairments. But if our patient is of low vulnerability, it will take beyond just putting urinary catheter for a few hours or 24 hours or 48 hours before patients can be treated to cognitive impairments.
Thank you, Ma. Okay, there's another question. Thank you for your presentation. I want to ask how postoperative cognitive dysfunction can be differentiated from a patient with dementia. Are there specific clinical signs and symptoms that differentiate these two, that is postoperative cognitive dysfunction and dementia? Please, if you have further questions, please put your questions in the chat box so that we can move ahead. The question says, are there specific clinical signs and symptoms that differentiate postoperative cognitive dysfunction and dementia?
I think they are both under the same umbrella of confusion, acute confusion. No, they are not acute. It's delirium that could be acute. They are both under the same umbrella of cognitive impairments, but dementia tends to be longer duration. It will be more than 12 months, as postoperative cognitive dysfunction is within 12 months. And for dementia, patients might not have exposure to surgery. Once there's exposure to surgery, exposure to anesthesia, then it will not be dementia. Dementia comes with physiological state that graduated to pathologic states. Am I able to? And then postoperative cognitive dysfunction can be reversible, but I think dementia is not. You just go through that lifetime treatment.
Thank you, Ma, for the answers provided. I think this will be our final question on this from the residents. The questioner asks, how can you quickly clarify the neurotransmitters involved in post-operative cognitive dysfunction? This person is asking about the neurotransmitters that are involved in the pathophysiology in the development of post-operative cognitive delirium and cognitive dysfunction.
Okay, the large neuronal, okay, the neurotransmitter acetylcholine, the dopa, the tryptophan, the large neuronal amino acid, we have the tryptophan, phenylalanine, GABA, endorphins. They have not been much implicated. Yeah. Dr. Afam.
Thank you very much, everybody, for your contributions, for your questions. I'll very briefly be handing over to Dr. Afam while we are still hoping that he gets on the platform. Someone has asked what drug is best used in the treatment of postoperative delirium after diagnosis. I think this will be the last question we'll take.
If you ask me single drug, I would say alloperidol, but you can still use COX-2 inhibitors. You can use if you suspect maybe it's from pain, you can do your multimodal pain management. If you suspect it's from if you suspect maybe it's from an overwhelming sepsis, you do the antibiotics. But for the cognitive impairment management, you can introduce an alloperidol. for the patients. And you can do non-pharmacological management as well. That would be more long-lasting than the medications. Thank you, sir.
Thank you very much, Dr. Salahuddin, for the presentation. Thank you for your responses to the questions asked. We will now be handing over to our academic secretary, Dr. John Afam, who will be anchoring the next segment of this lecture series. Dr. John Afam, sir.
Recording in progress.
Good evening, residents. Good evening, consultants who have found time to join this meeting. I am Dr. Queen Kalu, the President-elect and the Education Committee Chair of the NSA. I had earlier on seen Professor Nwaso on the call, and the Secretary of NSA, Dr. Salau. I think I also saw her on the call. And other consultants whom I might not have noticed. Thank you very much for finding time to join. And I believe that we have all found this very useful. It appears Dr. Afam is having network issues or something.
Yes, ma. Sorry, ma.
Okay. Are you back on the call?
Yes, ma.
Okay. I didn't see you for a while. So I want to thank everybody for joining. And if you have any topics that you think we should consider in these webinars, both for this residence webinar and for the general webinar, kindly reach out to Dr. Afam. He will present it to us at the Education Committee for consideration. In the next 2 weeks, on the 30th of September, we are going to be having our general webinar, and we are going to be interacting with very senior members of our society. We are considering mentorship in anesthesia training and practice. It's going to be a very interesting topic, and I would like you to attend. It's primarily for anesthetists, but if you have other colleagues who want to join the call, they should feel free to do so, because everybody will have a thing or two to learn. Thank you very much once again for joining. Dr. Afam, you can make your comments and close the meeting. Dr. Afam, are you still here?
Yes, ma. Good evening, ma.
Okay, so please, if you have any further announcements or something you can make and then we can consider the meeting closed for the day. Thank you,
Okay.
everybody.
Oh, thank you so much for the audience, ma. Good evening, everyone, again. I think we had a good turnout and a good meeting. I think, ma, you've said it all. This is a reminder that at the end of the month, we'll have the general webinar. So we are all anticipating that. Thank you so much, ma, again, and the Educational Committee and the NSA for the support and for the encouragement to keep this going. We are very grateful and we found it very useful. Thank you, ma. I think with that, in the absence of any new comments or contributions, we want to also specially appreciate the moderator for today, Dr. Etuk John, who is our presenter for the next webinar series, which will be next month. And the presenter for today, who was our moderator last time, Dr. Bolanle Salahuddin. As usual, the slides and the recording will be shared on the group when it's ready. And these are some of the ways that the NSA has been supporting our training, and we are very grateful to them. So in the absence of any other comments, I think we can log off. We spent 1 hour on the call. Thank you all so much, and special thanks to the NSA. Good night, everyone, and have a good evening ahead.
Thank you, sir. Good night.
Thank you, Dr. Etuk.
Good night. Good night, everybody.
Oh, Prof, ma, thank you so much, ma.
Well done. Well done,
Good evening,
speaker and
bro.
moderator. Good evening. Good evening. Thank you.